Good afternoon, everyone. This is Michael McGinnis from the National Academy of Medicine. I'm joining Tim Persons from the U.S. Government Accountability Office in welcoming you to today's webcast on artificial intelligence in healthcare. This is a product of a wonderful partnership between the National Academy of Medicine and the GAO on the future applications and indeed the current applications of artificial intelligence and machine learning to improving, tremendously accelerating the effectiveness and the efficiency of health and healthcare in the nation and indeed around the world. I'm going to just give a couple of words of background on the origin of our publication on artificial intelligence and machine learning, and then turn it over to my colleague Tim Persons, who will comment on the ongoing collaboration that we have together with the GAO and their work in this area. And then I'll come back and give a quick overview of the meeting agenda before we turn it to the our experts who've assembled with us today. And so again, with a special note of thanks, let me just to give a little bit of background. The National Academy of Medicine, obviously in the spirit of our role as advisor to the nation on matters of health, healthcare, and biomedical policy, has a special focus on the nerve center, if you will, of a continuous learning health system, and that's the digital infrastructure. And we have a digital health collaborative, action collaborative, which brings together with some frequency experts from around the nation. And the genesis of this project on in the development of our publication on artificial intelligence was at one of those meetings in which our two distinguished initial guests for our webinar, Sanu Thadni Israni and Michael Matheny, were present, and the project to move forward to the development of an expert-based assessment of the potential for the field grew out of the conversation at the meeting almost 2 years ago now. They, in their extraordinary fashion, then moved to assemble a wonderful cadre of experts to work with them and developed what we feel is a very important resource for the field, a National Academy of Medicine special publication entitled Artificial Intelligence in Healthcare, the Hope, the Hype, the Promise, and the Peril. It's very clear that we need to tremendously accelerate our learning process. That's never been more clear than we see with respect to the current pandemic and COVID-19. And we'll return to some of those issues in the course of the conversation. But with that brief note of background, let me invite my colleague Tim Persons from GAO to offer his words of welcome.
Thanks very much for that, Mike. Can you hear me okay?
Yes.
Great. So good afternoon or good morning, everyone, depending on which time zone you're in. Let me just add my thanks to Mike. So first of all, Mike, let me thank you. Thanks to Victor, the National Academy staff and our partnership, the chairs and the panelists that are speaking today. I'm very excited about the conversation and the experts that have helped us along the way and the studies that are being presented today. Also, thanks to the GAO staff who've done incredible work to bring to you today the piece of the discussion that will be covered later on in part 2 of the discussion. But really just setting up things, I'm the chief scientist at the GAO. I also am the managing director of our new team called the Science, Technology, Assessment, and Analytics team, which really does the oversight, insight, and foresight work for the U.S. Congress. Karen Howard is the director for the Science and Technology now in SDAA. She's going to tell you more about the team later. So I'll just save it for the fact that really setting up this meeting, I think context matters. So here are the numbers, right? We know that the US healthcare system is at an important crossroads and faces major demographic shifts, burgeoning costs, and transformative technologies. And by the way, all of this was pre-pandemic in its context. So I think the pandemic, as Mike rightly pointed out, just shows or beautifully illustrates the challenge that we're currently facing. Total annual healthcare spending in the US is projected to reach nearly $6 trillion by 2027, and that federal spending of that is 1/4. So the US government's a major customer, as it were, spender in that area. Every day, demographically, and for the next decade, this will be true. More than 10,000 Americans will turn age 65, already burgeoning the pressures on the Medicare, Medicaid system, and so on. And so this demographic shift is just illustrating, again, the challenges that we have now, again, even without the pandemic. But in short, the status quo is unsustainable. We're just not well positioned to rise to our collective challenges. Looking at today's COVID situation, we now have more than 1 million cases confirmed in the US. That's probably an undercount, by the way. And then we have more than 60,000 Americans that have died, also probably an undercount. Each of these lives, there are lives behind these shocking numbers. It's almost numbing in that case. So clearly, pharmaceutical interventions are needed. And as if the pandemic isn't bad enough, my team just issued a report yesterday on antibiotic resistance, which isn't the topic of this per se, other than it's related to the issue of we have another kind of slow, multi-creeping pandemic and antibiotic resistance and mortalities caused by that, with no solution in sight and no antibiotic arsenal to sort of answer that. And so into this, you really think about what it takes for drug companies to develop drugs. We're talking 10 to 15 years to bring a single drug to market. The average cost is between $600 million and $1.4 billion. And so we need to find a way to leverage these AI machine learning systems to reduce that time and cost to find new insights, and we need to do it now. It is a scary technology. It as yet has captured our imaginations ever since its inception by Alan Turing in the 1940s, all the way up to the recent Go beating system that Google put together. It has all kinds of promises in healthcare. It's why we're excited to be in this. This is just the first study in partnership with the National Academy of Medicine and its experts on drug development, but we're also working on a study now that we plan to issue later this year on the issue of supporting medical services, just how we deliver care better, more efficiently at lower cost, and so on. But really for today, it's really about how do we identify new treatments, how do we reduce failure rates in clinical trials, and generate result in a more efficient and effective drug development process, while at the same time mitigating the risks of the ethical, legal, economic, and social questions. And plus, not to mention one of the big ones, the psychological issue. We may feel like we're not in control in this, and that can be scary to us. Yet it's not a matter of if AI, it's how AI. So with that, I'll just again thank you all for tuning in today. Thanks again to our experts, and thanks again, Mike and the National Academies, for our collaboration. We look forward to the discussion today and continued partnership with you all. I'll turn it back to you.
Thank you very much, Tim. Not only for your leadership and partnership, but for what was a wonderful, succinct, but extraordinarily informative introduction to our conversation today. That conversation will have two parts, as has been referenced. In the first hour, we'll focus on the NAM special publication, which, as I mentioned, was called Artificial Intelligence in Healthcare, the Hope, the Hype, the Promise, and the Peril. The publication synthesizes current knowledge to offer a reference document for relevant healthcare stakeholders across the nation and beyond. It outlines the current and near-term AI solutions, highlights the challenges, the limitations, and the best practices for AI development, adoption, and maintenance, and offers an overview of the legal and regulatory landscape. We're going to lead off our conversation today with the co-chairs of the effort to produce the publication. Sanu Thadni Israni is the co-founder and executive director of the Stanford Presence Center at Stanford University. It's a center which focuses on balancing high tech with high touch in healthcare delivery. And Michael Matheny is a co-director of the Center for Improving the Public's Health through Informatics, and Associate Director of the Advanced Fellowship in Medical Informatics at the TVHS Veterans Affairs, and he's also Associate Professor in Departments of Biomedical Informatics, Medicine, and Biostatistics. Just a few housekeeping elements before I turn it over to our co-chairs. In general terms, please always keep your line muted unless you are called on to speak. If possible, turn on video while speaking to the group. And to enable video, just click the Start Video option at the bottom of your screen. If for questions and answers, which we hope we'll have time for, given the richness not only of our presenters, but of our audience. We have a very broad audience who have tuned in today. Thanks to each of you. And please type the questions into the Q&A located at the bottom of the screen on your Zoom interface. The format is fairly straightforward: your name, who's the question to, and the question itself. So now I would like to turn the webcast over to Sonu.
Thank you, Michael. Welcome, everyone. Thank you for joining us, and thank you to both the National Academy of Medicine as well as to GAO for the collaboration and the partnership for us to deliver this. Next slide, please. You heard about the publication that my colleague Mike Matheny and I co-led with the help of staff from NAM, which include Noor Ahmad and Danielle Witcher. Next slide, please. Technology. I spent 25 years in high tech before I came to Stanford almost a dozen years ago. And if there's one thing that sticks right in the middle of everything I do and think about in this space or any other space related to technology, it is a quote best captured in Yuval Noah Harari's most recent book called 21 Lessons for the 21st Century, where he writes, "Humans were always far better at inventing tools than using them wisely." Our goal with AI, to find solutions for everything, including the current pandemic, is to make sure that we can focus on the hope and the promise and not the hype and the peril. Next slide, please. The biggest peril has to do with healthcare inequity. AI needs population representative data, or we'll end up with what in computer science is called GIGO, garbage in, garbage out. The slide you see in front of you is not a photoshopped image, but a true image, and it could be anywhere in the world, including our own country. The privilege that you see of single swimming pools in every floor, and then you see what's on the other side where there is not a single pool, leave alone a bathroom. The reality is that when we seek solutions, AI needs both population representative data, so it needs to represent all populations that you see on this slide and in our lives in general. And it needs population representative teams to help develop the solutions. Otherwise, we will end up with biases and prejudices that we do not necessarily understand. Next slide, please. The other challenge is captured in Shoshana Zuboff's book called The Age of Surveillance Capitalism. While in our publication, we talked about how AI could reinvent medicine or become a patient's nightmare if you take patient data and store it in a cloud and use the expertise to unearth insights. But in the age of today's pandemic, we know and realize that we do need some form of information on who is infected and who else they come in contact with, etc. And in order to have that level of data, we also need to be very clear about how that data will be used, and more importantly, how it will not be used. Next slide. Next slide, please. COVID-19 knows no other. We are in this together. Whether we start with the social determinants of health, where shelter in place is difficult, if not impossible for some populations, to the reality of where what we're seeing in terms of infection and deaths. And the other that we see in our planet and in this pandemic have to do with race and gender and age, and whether one has a residency that is either rural, urban, or suburban, and so on and so forth. So when we seek solutions using technology of any kind, especially AI, which has the capacity to scale and have huge impact, far more than the individual bias of individual physicians, clinical team members, and or technicians, we need to ensure that we understand we have to have a solution that works for everyone and represents everyone. Next slide, please. Next slide, please. May I have the next slide, please? Sorry, one slide back. In our publication, we offer two frameworks for how to move forward. One is to implement AI using the lens of a human rights values, where we ask questions like, what do we value? What does it mean to be human-centered? As you heard Mike McInnes say earlier, the work we do at Stanford ensures that we do not forget the humans in the system, the humans who are the patients, their caregivers, their friends and family, and the humans that are on the clinical side, which are the physicians and the larger clinical team. We have to ask ourselves, how are we each responsible for what we deliver? And how do we define progress? In Silicon Valley and places like where I've lived for much of my life, often the discussion is around how can we advance innovation? And does that mean that we have to slow down in order to be equitable and inclusive? And I would ask, how do we define progress, quality of life, and well-being? Then there's a space of that says we can, but should we? Technology allows us to do all kinds of things. But what does it mean to do it responsibly? And then finally, the governance space about who knows, who decides, and who decides who decides. Next slide, please. The second framework we offer is the quintuple aim. We know that which is measured improves. And in healthcare, for a long time, we measured interventions based on the triple aim, which was the experience of the patient, population health, and reducing cost. After living with the reality of physician and clinician burnout and resilience, we added a quadruple aim on care team well-being. We argue in this publication that we must have a fifth or quintuple aim of equity and inclusion. Every intervention we create, we should ask, how does the person with the most privilege walk the journey and benefit from the outcome? And how does the person with the least privilege walk the journey and what is their outcome? Next slide, please. Next slide. Thank you. I'll turn it over to my colleague, Mike Matheny.
Yep. Thank you, Sanu, and thank you, Tim and Michael, for organizing the webinar. Next slide. So there are many opportunities and challenges in the successful conceptualization, development, implementation, and sustainment of AI technologies in healthcare. Some uses are such as artificial intelligence algorithms that are put into clinical decision support tools for individual patients, for deploying AI for a variety of clinical tasks and drug discovery, all the way to things like radiology image interpretation and identification of normal and abnormal lung segments to diagnosis of the likely abnormalities found in those images, even to things like back office administrative functions that might benefit from efficiencies gained by using these systems. So I'm going to sort of weave these into a little bit of the slides that I'm going to be talking about. However, I'm also going to weave in some comments relative to the COVID pandemic. Even though the pandemic had not yet started by the time the National Academy publication was released, many of the opportunities and challenges of AI remain relevant even when viewed through this lens. Next slide, please. And so when thinking of AI and the algorithms and technologies, it's important to keep distinct that it's when we talk about it, we talk about a a discrete set of mathematic equations and algorithms and computational pieces, but we're also talking about applications of AI. Many times what we end up talking about are those applications. In most cases, what makes them distinct is how they get the data in from the world and process them, and then how these algorithms then sort of output results into the world, whether that's in audio or video form or in the form of text. For example, in predictive analytics, one of the areas that's used a lot in drug discovery and clinical decision support and some other pieces is syndromic surveillance, which is where groups of analysts and scientists use publicly available data, such as process text reports from the World Health Organization, pharmacy data, social media posts, search engine queries, travel patterns from air transport associations and passenger volume data, and other information in order to try to predict infectious syndrome evolution. So in this, for the story of COVID, it's actually interesting. So Blue Dot, one of the surveillance engines, sounded an alarm on December 31st, and there was a lot of discussion around that. However, there was another AI model, Health Map, that also signaled even a day earlier. But I think what is sort of really interesting in this story is that just 30 minutes after the first AI algorithm signaled, there was a human analyst from ProMed that separately sent out a warning that was based on a synthesis of a number of different sources using artificial intelligence and other algorithms as more of an augmented or supported solution. And so in later conversations, even among the authors of the fully automated algorithms, they did disclose that they still had humans in the loop that were helping interpret the signals prior to their public release. Next slide, please. And so the challenge, one of the fundamental challenges for AI is data availability, data quality, data cleanliness, and interoperability. And so there's a lot of good news in that regard. The Cures Act has sort of released its final rules on interoperability, and the Office of National Coordinator has been moving those along. And some of those show great promise for being able to connect data across multiple electronic health record sources and other publicly available sources. But it's also really highlighted some of the problems. You know, as data are aggregated towards their utility for artificial intelligence algorithms, these algorithms require quite a bit of data in order to successfully make their predictions. COVID was such a novel and unexpected occurrence that it took some time for some of these data sources to be gathered in order to be useful for addressing the crisis. Next slide. And so another topic from the report that's relevant is sort of the issue around transparency and trust. So in many cases, it's important, we want to highlight that it's important for the data that's used for these algorithms to be highly transparent, to be published alongside these algorithms, and to be made available for users and patients and public to review. Because we've seen instances in the literature where biased data, when used to generate AI algorithms, can result in biased or unexpected or unintended consequences. There's also an issue around the performance transparency, which is really relevant to FDA and other regulatory agencies, and also the end users that need to know how accurate these systems are when they're using them for patient care and for other health-related activities. And I think, next slide, please. So I think, as I mentioned sort of in the earlier slide, one of the foci of the report is also a focus around humans in the loop, or a focus around human-supported cognition. And there will always be situations which AI could not have accurately predicted. I think another good example in the COVID crisis is that the data domains in many different areas completely went off the rails during the crisis. Recreation completely changed, transit patterns changed, healthcare utilization pattern changed, and many of the algorithms that were in use in these systems at the time lost their performance and lost their ability to predict. In fact, one of the most common terms I see right now when I'm reviewing AI algorithms and things are, we've COVID adjusted the algorithm in order to update it and make it more accurate during the pandemic. Next slide, please. Lastly, I want to make a point about the life cycle of artificial intelligence algorithms in healthcare. It's really important to consider issues around conceptualization, workflow integration, implementation, and surveillance One of the areas I want to focus on here, though, is that it's really important to provide automated systems in the background to monitor these algorithms and tools, so that as we go from hundreds to thousands to hundreds of thousands of these algorithms in practice and use, that performance aberrations and declines in performance can be detected quickly and addressed in order to promote safety and effective use. Next slide, please. So I just want to thank the publication co-authors and the Academy of Medicine for all of their work on this publication, and happy to pass it on to the next presenter. Thank you.
Well, and thanks again to both of you for your extraordinary contribution, and not only in the review of the publication, but in all the work that you did in orchestrating its accomplishment. We now have a wonderful panel to reflect from their perspectives on the issues engaged. And first we'll hear from, I'll introduce all of them, and then they will speak in turn. Jack Resnick, Mara-Lise Gorgens, Gil Alterowitz, and Glenn Cohen. Jack Resnick is a professor and vice chair of the UCSF Department of Dermatology. He also currently serves as chair of the American Medical Association Board of Trustees. After Jack, we'll hear from Mara-Lise Gorgens, who is a senior monitoring and evaluation specialist at the World Bank Group in the Health, Nutrition, and Population Global Practice. And after Mara-Lise, we'll hear from Gil Alterowitz, who is the director of the National Artificial Intelligence Institute. That's the Veterans Affairs. And he's working to rebuild AI research and development capacity to help veterans. And Glenn Cohen is the James A. Atwood and Leslie Williams Professor of Law at Harvard Law School and current faculty director of the Petrie-Flom Center. He's one of the world's leading experts on the intersection of bioethics in the law, as well as health law writ large. Each of these folks will speak for 6 minutes. Please make sure to only unmute your line when it's your turn to present. NAM staff will be controlling the slide deck, so again, please remember to indicate when you want to advance to the next slide. And it's my pleasure to turn things over to Jack Resnick. Thank you, Jack.
Well, I want to say thank you to Sanu and to both Michaels on the NAM side, as well as GAO for putting this session together. Excited to be a part of it. Next slide, please. So since a few folks are signed up to get CME for this, I thought it was important to put a conflict of interest slide. I don't have any traditional financial conflicts, but I do, as Michael mentioned, serve on the AMA board. And of course, my views about AI are influenced by the colleagues on the front lines that I see around the country as I used to travel and now webinar more. Next slide. So from the physician perspective, I think we're really focused on thoughtful design of AI at the front end. And I'm really pleased with the National Academies because I think this publication thoughtfully addressed doing just that. Physicians are pretty excited about the potential for AI, but we've all lived through the deployment of electronic health records, so we know what happens when end users are not involved in design or validation or implementation of a new technology. We really root our goals for AI as we do for other innovations in advancing the quadruple aim. And that leads us to ask a few questions. Questions like, does it work? Is it clinically validated? Even if it works, does it work in my practice for my population? Does it meaningfully address something important like chronic disease? Does it improve and re-engineer experience for the healthcare team to mitigate burnout? Is it streamlined, well-designed, user-centered, friction-reducing, integrated into our workflows? Does it reduce overall costs? And will I be sued for using it? And I'll come back to that. Next slide, please. There are a few things that I think really keep us up at night and where we're focusing our efforts at the AMA and where this NAM publication focused as well. And the first of which you heard already a little bit about from Michael is really around quality and transparency and trust. So physicians and patients really basically want to know which tools work. And to do that, we have to have strong published clinical validation, and those studies need to be done in the same settings where we're going to be deploying these tools. When you think about it, for a non-AI intervention, like a new drug with a randomized controlled trial, we really expect to know the details about both the control and intervention populations. And we don't always know that for new AI tools. We need similar transparency. Training data is increasingly being treated by AI innovators as sort of a trade secret, where we're seeing data fiefdoms, where a small number of corporations with access to rich data sets in some ways can stifle innovation. And some access to the data, training data, is really necessary for us as end users to figure out if and where designers went wrong. Illustrated at the bottom of this slide is a study about a melanoma tool. And as a dermatologist, I'm kind of excited about tools like this. I would love their help. This is one where after the tool came out, it was discovered retrospectively that in the learning set, doctors had been more likely to put purple markings next to melanomas they were about to photograph. And so if you put up a benign lesion, a mole, in this tool later, but you happen to mark it, it increased the odds that the tool would judge it to be a melanoma. So we think at a minimum, AI needs to explain its learned models and reasoning so we as humans can understand and trust the conclusions. Next slide. Privacy is also something we think a lot about, and we recently at the AMA adopted a set of new principles around privacy. We really think there needs to be a national discussion about consent for data use. The risk otherwise is that our nation suddenly realizes that their de-identified data have been re-identified by major data aggregators that they don't trust. And I'm personally worried that when they come to my office after realizing that, they'll be suspicious of all of us who seek sensitive info, including during clinical encounters, and be less apt to share. So we think innovation can still happen while providing meaningful notice and dynamic consent, and I hope we'll get to talk more about that. Next slide. On the regulatory policy side, you're going to hear more about this from Glenn on our panel this morning. I think the COVID crisis is actually informative about where regulatory policy can sometimes lag, and we really think regulation must be aligned with the level of risk. So we don't want to overburden low-risk tools or under-evaluate high-risk tools. There are clearly risks on both sides, and indeed, FDA guidance thus far has sought to exempt low-risk machine learning systems from regulation. When they think about risk, they recognize use cases. It recognizes disease seriousness. But we think as currently written, it basically misses scope. There's a very different level of risk when you're putting together a local sort of bespoke system to be used at a single health center, and when you try to commercialize a system like that across the country where they can be brittle and not work as well. It also misses whether the machine learning is supervised or unsupervised, continuous learning, or locked. Next slide. And finally, I just want to say a few words about liability. As physicians, we really think it's important that liability be assigned to those who are knowledgeable about a system's design and validation and best positioned to mitigate its risk and avert harm. This isn't just about tort liability and product liability, but really comes into discrimination as well. Sanu brought up the issue of inequities and addressing social determinants of health. Many of you are probably familiar with the litigation around the United Health tool that was initially designed to give additional healthcare resources to at-risk patients who might need them to prevent future health problems, but ended up with a substantial racial bias. We can get into the details maybe later, but it was essentially predicting costs rather than illness or needs, and it was influenced by historical inequities. So there's real potential with AI to be implemented unequally and further worsen access for vulnerable populations, or not be usable in small practices, or even have differential privacy rights assertion around paid apps or free apps. There's a lot to think about there. Next slide. So finally, in closing, I'll just come back to this slide that I started with. I think with AI, physicians are tremendously excited about the potential, and we're deeply engaged. AMA has even created its own innovation company in Silicon Valley. But our best shot at avoiding disappointment and maximizing potential is going to require involving end users at early phases of development and continually coming back to the same set of fundamental questions about enhancing patient outcomes and population health, about driving value, and about focusing on user-centered design that helps improve care delivery. Thanks so much, and I look forward to questions.
Thank you, Jack. And now over to Marlies.
Hi, good afternoon, and thank you for the opportunity. So I'm going to change direction somewhat in discussing whether AI has the potential to improve or impair health systems in developing countries. Next slide, please. And I think there are two sides to this coin, as the previous speakers have alluded to as well. On the one hand, AI definitely has the opportunity to improve. And I list these 5 examples that we see most frequently in the work that is done at the World Bank. Maybe by explanation for those folks who are not familiar, the World Bank is a multilateral development bank. We have an active health portfolio of around $15 billion in around 70 countries. And we recently announced a fast track facility for emergency COVID-19 funding of $14 billion. And we have 82 countries in which we either have active investments or investments being designed. The use of digital technology, including AI, is prevalent in our discussions and negotiations with governments. So where is it that we see the immediate potential of AI to improve and address some of the pernicious challenges in health systems? First of all, is in the very building blocks of a good health system and of a digitized health system, which is to create electronic health records, keeping in mind that in many countries, many developing countries, health records are still manual. They still consist of manual registers. So just creating those digital health records and leapfrogging from paper-based to electronic-based systems. Secondly is the potential for increases in efficiency, technical production and allocative efficiency, how we use scarce healthcare resources to deliver the best possible healthcare, and making decisions on where health resources are used. Thirdly is what we would call digital task shifting to address severe staff shortages and lack of specific cadres of health workers. Radiology is one such example where we've seen countries already starting to use AI-based tools to do the first line of screening with humans then in an augmented way, looking at a second line of screening to confirm positive cases. Fourth is in the population health sphere. In other words, micro-targeting where interventions are provided and being able to provide differentiated care for different kinds of patients and clients who are not yet seeking care. So ensuring that when we do vaccination campaigns, for example, we go to the right places where we've predicted there's most likely to be households with unvaccinated children, or when we do screening for diabetes, or we do screening for hypertension, that the screening, proactive community health worker based screening that is done in a way that we're most likely to target people who need it the most. And then lastly, and I think Matthew alluded to this, how the first signals of COVID-19 was discovered through AI, but using these non-traditional health sector data for early warning signs and sentiment analysis as we focus more on people-centered health and people-centered health systems. We want to make sure that we take demand side data into account, people's preferences, our clients' existing health seeking behavior into account, and not just think about it from a service delivery perspective. And these non-traditional health resources, health sector data have the ability to enable us to do so. But on the other hand, next slide, there is also the perils that AI can impair what is already fragmented, struggling, and vulnerable health systems. One of the previous speakers spoke about this issue of the exponential increase in what we call in the development terminology, pilotitis, where there are just so many partial siloed systems. Every new development partner coming in with a new idea and a new digital health tool. The government of Ethiopia did an assessment, for example, last year, and found 228 different mobile health systems and solutions in a health system that is run by the government, of which the government only knew of less than 40% of these. Each of those have data that are kept, that are not necessarily centralized. Data governance, data stewardship is a challenge, particularly in countries where there are no HIPAA-like regulations in place. And so we have these endless pilots because people keep coming up with new solutions instead of building on what is there. And I think the second challenge refers to what Sonu spoke about earlier, which is that as long as data access is not universal and data costs are prohibitive, which it is in many developing countries, the potential for AI or the lack thereof to exacerbate inequality in service delivery and service access and service quality is real, and we need to build this. In fact, the World Bank has a threefold strategy on disruptive technology that talks about building, boosting, and brokering, and building the digital infrastructure that is needed to provide free or very affordable health data access is essential. It's part of universal healthcare, and universal access to healthcare is making sure there is access to data. I also think that there has been in developing countries a disproportionate focus on the highest hanging fruit, which is an integrated clinical decision support system. Not saying that those are not a good idea, but there are many other lower hanging AI fruits that we should tackle first. Simple, straightforward solutions, making sure that a community health worker's app that tells her where to go and what to do, that it uses predictive analytics to send her or him to a specific household, and not just that she goes through all the households in her catchment area, one after the other after the other. I also think that the other challenge is around patient and provider confidence, right? That as long as we communicate, and there's still this tendency to communicate about AI in healthcare as a robot standing in front of me with a clipboard in their hands, right? Or a robot performing surgery, right? That's not the imagery we want to use, and this is not the way in which to build confidence, right? I think the more we can speak about and show through evidence how AI augments, frees up time of providers so that providers can connect with people and do what it is that providers can do best, the more we will build confidence in AI. And my last slide, in order to do that, I think there are 8 imperatives in developing country context that we need in order to make lasting progress. The first one is that we need to think about digital health and AI solutions as bouquets and not letting 1,000 flowers bloom. I think here in the US, that lesson's been learned many times over, and I'm glad to see that there's some real movement towards interoperability. But it also means that we need to prioritize funding for the integration of existing solutions and not building another solution. It is never as, specifically for tech companies that want to start something new, it's always the least attractive option is to integrate 2 solutions, then come up with a new, better solution. But that doesn't help countries when they want to build integrated systems with integrated solutions. My next point, and I saw that Ger is from the FDA is on the panel later today. I'm sure he will speak about this as well, but is about the issue of evaluation, value, and cost effectiveness. Just because it is new doesn't necessarily mean it is better. Just because it's technology doesn't necessarily mean it will solve the problem in a better way. We need to make sure that there are metrics and methods for doing economic evaluation and understanding the cost effectiveness and cost benefit of AI solutions versus non-AI solutions. Otherwise, governments are making decisions not based on the evidence of which solutions will work best in their constellation, their bouquet of digital health solutions, but they will make ad hoc decisions, and that can never lead to an integrated systems. We also need to consider system disruptions and linkage to existing systems instead of this very fragmented, piloted, everybody holds onto their own data approach. And in fact, part of people-centered care, I think as previous speakers, Matthew also mentioned, is people and patients, clients having the right to carrying their own data and being able to decide who gets access to which of their data instead of providers making those decisions on their behalf. And the fourth area that we are focusing on as well is on this issue around, do we digitize and then build AI into it? Do we create the community health worker solution and then we kind of add predictive analytics on top of it? Or do we design these systems with AI embedded into it already? I think that if AI solutions work well, they're invisible. We don't see them. They're just part of the regular workflow of how healthcare gets delivered. And these are important imperatives because I think people get excited about data science and AI, and they're focusing on the method and the application, and not focusing on the problem that we're looking to solve. And the fifth issue, which I think I alluded to as a possible peril, is around the issue of patient and health worker confidence. That's going to come with time. We know the health sector has been one of the slowest sectors to take up AI in the workflow of how healthcare gets delivered. But it is important, but it's going to require that we use different data sets, different approaches and incentives, behavioral nudges to ensure that we build this confidence that what I have in my hand, I understand why it came to the conclusion, why it made this specific prediction, that we have less black box AI, but a reproducible and understandable AI. The last area is around the area of regulation and governance. This is a significant challenge in developing countries where often there are no health data regulation or very poor regulation in place. I think this notion, the World Bank's 2020 World Development Report is on data, and one of the strong points that is being discussed as part of that global report is around this concept of data stewards and data governance. How do we ensure, not just in the health sector, but overall, that there is good, solid data governance in place, recognizing that we're playing catch up when it comes to data governance and regulation, because there are many data-driven and data capturing solutions out there already, many applications these days, and many of our ways of doing business means that we're already generating, capturing, and using data. How do we retrofit regulations and governance in a way that doesn't break down these systems, but make sure that there's pragmatic governance in place and data stewardship so that these data can be used for the best possible benefits? Thank you very much.
Thank you very much, Marlies. And now over to Gil.
All right. Yeah, thank you very much. I'll be talking a little bit about the NAM recommendations and implementations of some of those recommendations that we're looking at the National Artificial Intelligence Institute with the VA. So if we could have the next slide, please. So here we have outlined text from the report in terms of 7 of the recommendations. And if we go to the next slide, we'll take a look at some of the ones that we'll highlight here. The dialogue around transparency. Oh, if you could go back. So we can, yeah, there we go. The dialogue around transparency and trust should change to be domain and use case differential. And the near-term focus should be on augmented intelligence rather than full automation. And then in the next slide, we'll take a look at how we're doing that, looking at implementing those. And this is, talking about, so the VA has a number of different projects going on around AI. There's hundreds of different medical centers doing research and working in different areas. One of the powerful areas is around collaborating with different organizations outside the VA to leverage some of that expertise, and so we can build that AI R&D capacity. And one of the ones highlighted here was actually a paper published in Nature this past July around predicting acute kidney injury 48 hours in advance. And so that early warning really enables time to take preventative action, whether it be through enhanced fluid retention or other mechanisms. And that can really help prevent the kidney injury from happening. In the past, it would generally be found after you have altered creatinine and other lab values that actually already indicate that kidney injury happened. And so this is another example of where looking at the particular use case and then taking into account what the AI is predicting and augmenting the information being provided to the physician for them to make a decision based on that. In this particular example, the data was encrypted and encoded in such a way that when the analysis is done, you can't actually see the underlying information, but you can actually then through collaboration with the VA, analyze and find out what is the predictive ability of that information. And so kind of pioneers a few of these issues around how do you work together around different areas as well. So let's go to the next slide. And one of the couple of others and that I'll highlight from the report and how we're looking at it. So developing and deploying appropriate training and educational programs to support healthcare AI, and balancing degree of regulation and legislation of AI to promote innovation, safety, and trust. So if we look at our next slide, certainly the VA has a number of different programs. There are training programs, for example, around the big data BD STEP program that enable collaboration with academia and others around leveraging fellows to work on VA data. Another example of, and something we're working on in the NAI, the National AI Institute, is around rapid prototyping and piloting. So we'll work to identify the specific pain points for veterans and work collaboratively on a pilot to pilot a use case where AI can really help in that area and leverage the amount of VA data to bring it into perspective by working collaboratively with academics, with industry and others to build that out. So if we go to the next slide, we'll see one of our programs that recently won a government innovation award is the AI Tech Sprints. And we see a couple of items here. The Girls Computing League is a group made of students who have worked and created AI-based applications to enable veterans to search for clinical trials that may match them, and uses deep learning and in natural language processing to be able to find trials that work for the veterans using the veterans specific medical information that they get through this application programming interface through the VA. And then on the right, we see an app around coordinating care for veterans, and you can see here an image processing application with machine vision to detect, in this case, you see the hand of the patient and a few medications there, and it's able to detect which medications, how many medications they have, to see if it is, if they're adhering to their schedule, or if there's a new medication that it can't identify, or if there's a medication they're missing, and so forth. Just one example of a couple of the applications and platforms that have been developed as part of the AI Tech Sprint. Let's take a look at the next slide. Just to mention also on that, those last two were actually recognized in a national competition and received recognition through, which included in one case a prize for the future of health, and noteworthiness by the Chief Information Officer from the Executive Office of the President. Next, I have a couple of, you see here, recommendations. One, around population representative data accessibility, standardization, and quality being vital, and ethical healthcare equity and inclusivity being important to be prioritized, and leveraging of existing frameworks and practices within the learning healthcare system, human factors, and implementation science as being important. We'll see that in the next slide, where we're looking at pioneering new and representative data, where we know that veterans are facing physical and mental health challenges at disproportionate rates, and we can leverage existing frameworks in AI and ML and work across the VA to kind of build that AI R&D capacity to be able to understand items such as quality of life determinants for vulnerable populations. In fact, one work in this area leveraged some non-traditional health information around some polling data, actually, from Gallup. McCritis et al. Have found socioeconomic factors matter more than demographics and geographic factors in predicting physical well-being for veterans. And so there's quite a bit of a look at the results and highlighting the importance of human factors when looking at healthcare. So if we go to the next slide then. Just wanted to close with a link to our new institute. It just got launched actually for Veterans Month this past November. And just include an email if people have questions, contact, or are interested in potential collaborations going forward. Thanks a lot.
Thank you, Gil, and congratulations on the Institute. And we'll turn it over to Glenn.
Thank you very much. No slides. I know it's a little heretical, but I'm a lawyer, so I'm allowed to be heretical. I'm going to mostly comment on the great chapter by Doug McNair and Nicholson Price, Healthcare AI, Law, Regulation, and Policy in the book. And 4 themes I want to draw out. First theme is just quirkiness about how FDA has cut up the pie of its regulatory ambit. And it's not FDA's fault, as the chapter details, in part based on how Congress intervened through the 21st Century Cures Act. There's some peculiarities about what authority FDA does and doesn't have and how it's chosen to exercise that authority in this domain. Another way of putting it, if I said, here's a problem, there's a lot of AI being introduced into healthcare. You're an agency that often does ex ante review of things before they become available. What things should you review? The answer you get would be quite different from what FDA is kind of pushed into. It's worth noting the distinction between clinical decision support software tools, including clinical AIs, that replace health professionals' role in making a determination for the patient, and those that simply provide information to the professional who can take into account that information and make an independent evaluation. FDA deems the first to be a medical device and subject to medical device regulations. Under the 21st Century Cures Act, though, if a CDS product has multiple functions where one is excluded from the definition of a medical device and another is not, FDA can assess the safety and effectiveness to determine whether the product should be considered a medical device. It can also regulate the product as a medical device if it finds the software would be reasonably likely to have serious adverse health consequences or meet the criteria for a Class 3 medical device. Now, this gets quite complicated, and partially it's because we're backing into a pre-existing device approval strategy and design and saying which parts of AI are amenable to it, which are going to be treated as predicates to a pre-1976 kind of device, for example. And they do a good job, the authors in the chapter in the NAM book on this, but there's a lot of elements about it that I think are quite not ideal, and maybe we should use this as a moment to think a little bit more about blue sky thinking of what an ideal regulatory authority would look like, and also take a peek at what other countries are doing. So that's the first theme. The second is this thing about the locked versus unlocked AI problem. And the chapter does a good job of being almost exactly up to date on FDA actions. They mention a late-breaking one, which is the FDA proposed regulatory framework for modifications to artificial intelligence, machine learning-based software as a medical device, SAMD. But perhaps this point about locked versus unlocked could use a little bit more airing out. We did a paper in Science in December 2009, Algorithms on Regulatory Lockdown. And as we put it, it's a difficult regulatory problem. Once an AI ML is deployed, it can learn and thereby alter its performance behavior, much the way a medical resident learns on the job. This is an advantage of AI, but it creates what we call the update problem. And from a regulator's point of view, it's a design challenge. You have 2 polar approaches. One pole would be for a regulator to permit marketing of only a locked algorithm and require any change to go through a complete new pre-market review. The opposite pole would be to treat the initial marketing authorization as permitting the AI ML maker to update the algorithm without any further regulatory review. Now, obviously, when you put it that way, both of these are unsatisfactory, but determining what might be available in between is no easy task. In our view, the best way of thinking about this is as a continuous risk monitoring approach with techniques like retesting, simulated checks, and adversarial stress tests inspired by fintech, among others. But these are all quite different from the way FDA has traditionally viewed things. And again, we think some open sky thinking about this might be helpful. Third theme, explainability and its discontents. I want to praise the report, and particularly a great chart on page 182 for situating explainability as only one form of transparency and indicating that while there's a current fetish for it, it's worthwhile to pause as to why we want explainability and what problem we think we might be solving with it and what's missing with other means. So they do a good job of distinguishing dataset transparency from algorithmic transparency from architecture transparency. But I want to take us up a level. And I want to use an idea from the philosopher Alex John London that I think it's useful to distinguish the importance of knowing why X works from knowing that X works. Great example. We really have no idea why aspirin works. We have lots of evidence that it works. And when one realizes this, it might be better to frame the question as to be a little philosophical a bit about epistemic warrant. How much confidence do we have this is going to improve patient care? Now, explainability might be one way of having a warrant in that belief, but it's only one. And sometimes explainability about a mechanism tells us very little about whether something does work. Thus, the slogan should be less explainability, more clinical testing, including in-hospital installation analysis, because there is this possibility that just because something works in one place doesn't work anywhere else. Okay, last theme, optimal liability design. And now we want to be thinking about this, that a lot of the thinking has been about how physicians are going to face liability. I've written about this, happy to say more during the Q&A, but I want to make it more complicated by putting the following idea in front of you. In fact, we have multiple players in the system, makers of AI, hospitals that buy it, physicians that use it, insurers that reimburse for it. And for each of those actors, we have to think what's the optimal mix of liability as between them. In particular, fault versus non-fault system. We could have something more like vaccines, which is collectivized. Questions about insurance. Could we have a secondary insurance market? Questions about contractual resorting. To what extent are we going to allow there to be a shifting of risk between the parties through contract? Lots more to say about this, but I said 6 minutes, so I'm stopping there. Thank you very much.
Thank you, Glenn. And you left us with a teaser. Thanks to all the panel, really extraordinarily efficient and informative presentations. It's now my pleasure, underscoring those thanks, to turn it over to Tim Persons of the GAO to lead us through the second part of the agenda. Tim?
Yeah, thanks, Mike. So as I mentioned at the top of the session, we have been thankful and privileged to be partnered with the National Academy of Medicine and the many of these experts that you've heard on today. I'm going to be turning it over to Dr. Karen Howard and Rebecca Parkhurst, who are two of our technical staff. Karen is the director of our science and technology work, and Rebecca is a senior physical scientist with the GAO who was the project manager for the report. So, but as I mentioned at the top, this is one of 3 studies. We have issued this this past December. In partnership with NAM, we're in the middle of a second study due out later this year and scheduled for a third study in the 2021 timeframe on AI for diagnostic support. So with that, let me just turn it over to Karen. Please go ahead and kick us off. Thanks very much.
Next slide, please. Thank you, Tim. For those who might not be aware of who GAO is, just a very brief introduction before I turn it over to Rebecca. GAO is a nonpartisan agency, a federal agency, but we're in the legislative branch, a little bit unusual. When most people think of federal agencies, they're thinking of executive branch agencies. We do our work primarily to assist Congress with its insight, oversight, and foresight needs. Next slide, please. Our team in particular, STAA, Tim introduced us at the beginning. Our talk today is going to focus in the upper left corner of this slide, the technology assessment piece. Technology assessments are a set of studies that GAO does normally at the request of Congress, where we're looking at a particular technology, in this case, artificial intelligence, and we're looking at applications that it has. Again, the study we're about to talk about is going to look at artificial intelligence in drug development. And in this case, we're diving into what the technologies are, how do they work, how mature are they, and what opportunities and challenges might they present. Next slide, please. And unlike the work you just heard about, which did result in recommendations that were nicely spelled out by the panel you just heard from, we do not do recommendations in technology assessments. Instead, we do policy options. And the goal there is to present policymakers with options for ways that they might consider enhancing the benefits of a technology and mitigating its challenges. So with that, I'll turn it over to Rebecca. Thank you.
Hi, sorry, I was muted there. Next, I'm going to talk a little bit about our December 2019 report on machine learning and drug development, which can be accessed at the URL listed on this slide for those who are interested. As Tim mentioned earlier, this is the first report in the series on AI in healthcare, but it's also the second TA-GAO has conducted on AI. The first, which was published in 2018, was a more general survey of the field, which helps underpin many of the definitions that we use in this report. As one component of this review, the NAM provided expertise developed through their special publication to help us and others at the National Academies assemble a meeting of experts in the field. The collaboration also resulted in the co-branded report, which contains both our technology assessment as well as field background on AI in healthcare from the NAM. So before diving into the content, just want to thank everyone who worked with us on the report and who's here today, including the rest of the GAO team, our colleagues at the NAM, and all the panelists. So as Tim mentioned earlier, developing and bringing a new drug to market is lengthy and expensive, taking from 10 to 15 years and costing hundreds of millions to upwards of $1 billion. As shown in the flow chart, during drug discovery, researchers screen thousands of compounds to identify a few promising candidates. Then these candidates undergo preclinical safety testing to further narrow the field to one or more compounds. In clinical trials, drug candidates are typically tested in increasingly larger groups of humans for safety and efficacy, with approximately 10% of candidates that enter clinical trials succeeding and receiving FDA approval. It's clear from this process that significant time and resources are often spent on drug candidates that ultimately fail. Advanced analytical capabilities, such as machine learning and related AI technologies, are enabling the industry to take advantage of the increasing availability of biomedical and health data in the search for new drugs to prevent, treat, or cure serious illnesses. Next slide, please. In our review, we found that drug companies use machine learning throughout the drug development process, and we identified and assessed select examples in the first 3 steps of that process. In drug discovery, researchers use machine learning to identify new drug candidates, screen known compounds for new therapeutic applications, and design new drug candidates, among other applications. Although stakeholders and literature emphasize that computational discoveries must still be validated experimentally. In preclinical research, researchers use machine learning to augment preclinical testing, for example, as a complement to animal models, which can be poor predictors of human response to drugs, and also to predict toxicity before testing drug candidates in humans. In clinical trials, researchers use machine learning to improve clinical trial design, including helping to select and recruit patients for clinical trials and move clinical research towards precision medicine. Stakeholders in the literature emphasize the importance of using algorithms that are fit for purpose and noted that while advances in deep learning have generated a lot of excitement, those techniques come with a high computational cost and may not always outperform more classical techniques. Next slide, please. We heard from a variety of stakeholders that machine learning could be a transformational technology for drug development. Machine learning can make the process more efficient and effective, decreasing the time and cost required to bring potentially more effective drugs to market. Getting drugs to patients in need more quickly could save lives and reduce suffering. Lower R&D costs could also allow drug companies to invest more resources in disease areas that are currently not considered profitable to pursue. So for example, as conceptualized in this graphic, researchers can use machine learning to virtually screen millions of compounds rather than thousands and at a lower cost. Using machine learning to augment preclinical and clinical testing could also help researchers to weed out compounds that will fail, saving time and resources that may have otherwise been spent on their development, and also help to identify successful compounds sooner. Next. Through our review, we identified 5 challenges hindering the use of machine learning in drug development. Research gaps, including both gaps in basic biomedical sciences as well as in domain-specific machine learning, such as how to represent chemical and biological structures to machine learning algorithms, present a significant challenge to advancement in the field. The shortage of high-quality data is another major challenge. Data quality issues can stem from a number of causes. Data not collected for machine learning purposes may not be machine readable. Data are often not standardized, and data can be biased. Historical biases in health data, for example, could potentially skew outputs from machine learning models, causing differences in the effectiveness of drugs across subpopulations. Accessing and sharing data can also be difficult. Acquiring, curating, and storing data is expensive, There's uncertainty surrounding privacy laws, including HIPAA, and organizations may be reluctant to share data that they consider proprietary. Next. In the workforce, a shortage of skilled and interdisciplinary workers presents hiring and retention challenges. Both drug companies and regulators struggle to compete with the high salaries offered by big technology companies when recruiting data scientists. Stakeholders also stress the importance of bridging the cultural divide between biomedical and data scientists and creating interdisciplinary teams. Lastly, uncertainty about regulation, for example, what information or data, if any, FDA will require for approval of machine learning applications in drug development, as well as uncertainty about the federal commitment may hamper adoption of these technologies. Next. We identified 6 policy options as well as opportunities and considerations of each in response to these challenges. In response to the gaps in research and data quality challenges, policymakers could promote basic research to generate more and better data and improve understanding of machine learning in drug development. This policy option could result in increased scientific and technological output by solving previously challenging problems, or could result in the generation of additional high-quality machine-readable data. However, basic research is a long-term investment with uncertain benefits, and this option would likely require an assessment or reallocation of available resources from other priorities. Next. In response to the data access and sharing challenge, policymakers could create mechanisms or incentives for increased sharing of high-quality, secure data held by public or private actors, while also ensuring protection of patient data. This policy option could help realize the potential benefits of machine learning in drug development, including reducing the time and cost to bring new drugs to market. However, increased sharing of data would likely require coordination of multiple stakeholders and incur setup and maintenance costs. Additional considerations are the legal consequences of improper data sharing, cybersecurity risks, and reluctance of organizations to share proprietary data. Next. In response to the 2 data challenges, policymakers could collaborate with relevant stakeholders to establish uniform standards for data and algorithms. This policy option could improve interoperability by allowing researchers to combine different data sets. It could also support efforts to ensure that algorithms are explainable and transparent and could assist data scientists with benchmarking. However, standards development is a time and labor-intensive process that typically requires consensus from a multitude of stakeholders. Next. In response to the workforce challenge, policymakers could create opportunities for more public and private sector workers to develop appropriate skills. This policy option could provide a larger pool of skilled workers to fill roles at the intersection of machine learning and drug development, better positioning organizations to realize its potential benefits. It could also improve communication between workers with different backgrounds, enhancing interdisciplinary teamwork. However, workers trained in data science may seek higher paying positions in other fields, and creating these kinds of development opportunities may require an investment of time and resources. Next, please. In response to the regulatory and federal commitment challenge, policymakers could collaborate with relevant stakeholders to develop a clear and consistent message regarding regulation of machine learning in drug development. This policy option could help increase the level of public discourse surrounding the technology, as well as understanding among regulators and the public. Increased certainty surrounding how, if at all, regulators will review the use of machine learning in drug development could encourage investment in new technologies by drug companies. However, this option would require coordination between agencies and other stakeholders, and if new regulations are developed, it could result in increased compliance costs and review times. Next. Lastly, we present the status quo as an option, in other words, allowing current efforts to proceed without intervention. In this case, it's possible the challenges we described earlier could be resolved through existing initiatives. However, alternatively, these challenges may not be resolved or may even be exacerbated. Next. So that wraps up the discussion of our part of the co-branded joint publication. Again, we'd like to thank all of the attendees for joining us today. And I also I want to thank the rest of the team at GAO who worked on this report, in particular, John Van Aster, Caitlin Darden, and Matt Hunter. If you have any follow-up questions for us, please feel free to type them in the Q&A chat box, and we look forward to hearing the interesting panel discussion. Thank you.
Okay, thanks very much, Rebecca. And so we're going to have three panelists go at this point in terms of who had worked with us in the GAO joint NAM study. And so we're going to start off with Ken Getz of the Tufts Center for the Study for Drug Development, who will be followed by Dr. El Zarad of the FDA Center for Drug and Evaluation Research, and finally with Danielle Friend of the Biotechnology Innovation Organization. So Ken, please take it away.
Great, thank you very much. And I want to thank the National Academy of Sciences and GAO for the invitation to share my reactions to the report. And I want to put my comments in context. At the Tufts Center for the Study of Drug Development, I direct a team that looks specifically at the economics and the management of drug development operating activity. So our grant-funded studies really assess corporate strategy and practices and their impact on performance and efficiency. And over the past several years, we've looked extensively at digital disruption and transformation and how it has impacted clinical trials operating activity specifically, so that later stage area that Rebecca was talking about. Most of my comments really relate specifically to many of the issues that operating managers, executives who are working with scientists to speed up drug development to ensure quality, but also to drive higher levels of efficiency. If we can just go to the next slide. And overall, I found the report very thoughtful, very insightful, very useful, but I had just some other considerations and insights that might receive more emphasis, and they relate to a couple of key areas: the challenges that are associated with a really diverse source of data types, and other speakers have alluded to this. I'll expand on that. Many of the insights that I think relate to policy-oriented actions and more practical ways that we can approach addressing these challenges are associated with data sources as well. So I think that'll help frame my comments as we move into my last slide, which will touch on the policy-related areas. So let's begin by just looking at some recent data that comes out of the Tufts Center, just looking at data volume and sources. And we've seen dramatic growth in the volume of protocol-specific data that's collected to support the demonstration of safety and efficacy in our studies, as well as many other objectives and endpoints, including comparative effectiveness and risk-benefit, as well as quality of life improvement. On the left-hand side, you see the results of a survey that was conducted among executives across more than 250 pharmaceutical and biotech companies. And what you notice is that the data is coming from a wide variety of areas, many of them specifically operating areas that include clinical trial supplies, adverse event reporting, the routing of documents, trial master files, for example, the collection of cycle time data and performance at the investigative site level, grant payment related information and where the grant payments might be in process, because obviously the financial performance of providers is a critical way that we secure that we have all the necessary parties involved in supporting our research activity, and many others that are shown here. The point that I'm making is that so much of the data, that can be supported by machine learning and associated AI activity is operational data. On the right-hand side, in a survey that we conducted of over 100 companies, when we asked what their top needs are for use of machine learning and AI, several of the top areas related to supporting operating decision-making, helping to really streamline activity and to also ensure efficiencies, primarily economic efficiencies in the work that's conducted, and to also apply more automation to so many of the areas that ultimately support drug development, very complex drug development activity. If we go to the next slide, this also comes from that study of 114 pharmaceutical and biotechnology companies. And here we're showing you box plots with the dispersion of responses for a variety of domains where we ask companies to rate the level of maturity within each of these broad areas. And a couple really stand out as the least mature areas, including regulatory and clinical operations. You'll notice that the earlier science areas, including drug discovery, as well as the supply chain area, are two areas where machine learning and AI have seen longer use and application, although much of it has been really in the pilot arena as opposed to broad implementation. But again, I just want to highlight the notion that within clinical operations itself, there is very aspirational need for machine learning, but there are a number of key areas that could be emphasized more in the report. If we go to the next slide, just one other place I want to touch on that also could receive more emphasis is in culture and organizational leadership. And I know a few other speakers today have touched on this area. We know, for example, in another recent study that we conducted, that a very small percentage of companies have actually implemented a formal data strategy, a data roadmap, if you will, that guides all functions supporting drug development activity. And an even smaller percentage, 21%, report that they have a formal data governance policy. As one company executive put it, so much of the use of data and sophisticated analytics is really within sort of the Wild West today, in the absence of having formal governance and formal strategy that's guiding the organization in a focused and uniform way. Rebecca touched on some of the challenges associated with training and HR, and that's really been underscored in a lot of our survey work. We know that a large number of companies tell us that they're looking at establishing the data scientist role, but many organizations really do not know fully what that role entails and how to train for it. In fact, we see very, very small percentages of companies that are offering any kind of formal training today, and an even smaller percentage that tell us they believe they have staff in-house who even possess the skills necessary to use machine learning and AI adequately. So I'll close with my last slide, really looking at the policy options area and the 6 policy areas, Rebecca, that you highlighted. And there are a couple of key places that I wanted to emphasize here, and these relate more to, again, some of the operating areas that where machine learning and AI could really make a dramatic impact. And it includes more collaborative, open innovation use of AI and shared data sets, where we can actually apply more measurable return on investment concepts in order to promote and incentivize companies to invest even more extensively in broader implementation of all of the areas that are necessary to drive broad or wide adoption of machine learning skills and machine learning support. And there are a couple of critical places in particular that relate to the human capital area that I wanted to emphasize. One is to really rely heavily on not only the use of regulatory clarity, but also to stimulate more public-private as well as pre-competitive consortia to focus on 5 key areas. The first is digital thinking principles and what are some of the staff competencies or personnel competencies that can really be emphasized in this new environment. We haven't really seen within drug development a very clear picture for what that skill set might look like. As I mentioned earlier, to really encourage the need for a formal data strategy and a data governance policy within organizations. And our research has shown that those companies that have already implemented these particularly important mechanisms enjoy higher levels of reported efficiency. Hiring guidelines, and Rebecca, you touched on this, that competitive threat from the tech sector in particular is one of important note. And we know that many executives within drug development are very nervous about being able to compete for a younger labor pool when you have so many very, very attractive technology companies in other sectors that are drawing that data scientist capacity and skill away from the pharmaceutical industry. Many executives note that it's our mission-driven approach to improving public health that is one of the critical ways that we can ensure that we attract a younger community to really focus on giving their skills to support such an important endeavor, the development of new treatments and therapies. And lastly, as we relate or think about candidate identification, we've seen a lot of anecdotal reports of more expansive ways that we can think about identifying candidates and new personnel, including hackathons and other ways that are more in line with some of the newer approaches that companies and other industries are using to identify new talent. So these are just some of the other areas that we can think about that fall within the policy options that were highlighted in the report. And with that, I'll turn it back over to you. And I thank you very much again for the opportunity to share some of my thoughts with you today.
Thanks very much, Ken. I appreciate that. Especially, I would amplify your statement. A lot of this really is about organizational and cultural change, as you're pointing out. So with that, let me turn it to Dr. Khair El-Zarad of FDA Center for Drug Evaluation Research. Thank you for your work, and please take it away.
Thank you very much. Do you hear me? Okay, perfect. First of all, thank you for this opportunity to the National Academy and to the GAO. I really appreciate this continuation of focusing on this important effort and this important technology in general that have a lot of potential across the board. I'm from the Office of Medical Policy at the Center for Drugs, and the Office of Medical Policy, in addition to the initiation and development of medical policy, we have a think tank, similar to a think tank function, where we try to anticipate new innovations in technology and how our policy frameworks, regulatory frameworks can handle them. And I think that's a really important function, and increasingly so as we see the digitization of the world of drug development and therapeutic development in general. Can you get the next slide, please? Thank you. So the GAO report was a very important perspective, and it outlined really multiple important aspects. And I want to highlight some of them, specifically those that were not mentioned in previous presentations. But in general, we're all aware right now the potential for AI to be used across the spectrum of drug development and therapeutic development is really all the way from call to all the way to even the mechanism of understanding the mechanism of disease, understanding the biomarkers, to repurposing of existing drugs, approved drugs in the market. I want to highlight just one aspect here, that's the design of clinical trial and optimizing clinical trials. Before I joined the FDA, I was at NIH, and I can tell you one of the most critical needs is to make sure that our clinical trials succeed. And many clinical trials fail for the simple reason of lack of recruitment. And I think that's really an important issue to think about. I know when you think of AI, we think of the innovation, the bright new thing, but how can AI really help us optimize our existing practices or existing tools? I think it's a very important aspect. How do we make sure, and we owe it to our patients in a way before we recruit them in a clinical trial, that this clinical trial have the highest potential of success. So how do we do that and utilize AI to serve in that? This is just a couple of articles there that highlight the need for a kind of an intelligent approach to the regulation of AI, and I'm going to explore that a little bit further. Next slide, please. So all of you are familiar with this slide on the left, where it shows the long and the very expensive journey to develop a single drug. And of course, all of us share the interest in minimizing the time and minimizing the cost to get there, to get to that promising drug. For us at the FDA, one additional challenge is how to get there, not just fast and in a very efficient way, but also how to maintain the substantial evidence standards that we have while we're getting there. And I think this is really an important issue across the board. I think Glenn mentioned a little bit our regulatory frameworks that we have and how we have to function within that. I believe we have a lot of thinking to do in understanding how can we utilize our current framework to maximize the efficiency of our drug development pathways. And this is something I'm going to highlight further a little bit. Can I get the next slide, please? So before moving forward, I just want to say something about why it's really important for us to come together as this meeting, for example, to start discussing AI and other digital tools. I see AI as part of the continuum of all the innovation, technical and digital innovations we're seeing. And I really believe there is an evolution that's happening around evidence generation. We rely on clinical trials as gold standards, and I think they are that, and they're going to continue to be that. But how do we start utilizing other streams of data? And I just put this kind of complicated slide here to show you the multiple streams of potential health data that could come to you from using multiple devices, all the way, you see the rings, you see the Apple Watch, you see even glasses now with chips and providing data on you. We've all heard about the COVID-19 and how certain rings can provide you with a certain risk for developing the disease. So we're seeing this conglomerate of innovations that's coming together, including certain designs of clinical trials, decentralized clinical trials is an example of that will potentially produce evidence for us, and how to make sense of that evidence that could feed into regulatory decision-making and could feed into healthcare decision in general. On the very left, we have the Real World Evidence Program that the FDA initiated under the 21st Century Cures Act. And this is an important aspect where we have to look at health data that's not generated originally for research purposes, the EHRs, the claims data sets, but also data generated via digital tools, and how to maximize the utility of this data to support regulatory decision-making. So just to show you the spectrum of all this that's happening at the same time. Can I get the next slide, please? So when FDA really, if you look at the spectrum of the guidances that were developed all the way back, 5 and 6 years from now, you will see how there is a preparation for an increasingly digital world. For example, guidances here, but for example, to you, electronic source data, electronic informed consent, electronic record and electronic signatures, and the utilization of EHR, electronic health records. Also, our colleagues at Center for Devices produced a framework that, again, was mentioned before on the regulatory framework for artificial intelligence and machine learning. And I think they highlighted a lot of really important aspects there. And they were very frank about the dilemmas that all of us face regarding, for example, adaptive or learning algorithm. And they provided some thinking on how real-world data generated by those adaptive or learning algorithms can be incorporated back in the way we evaluate those algorithms. And I think it's really good and important discussions to have. An example of current work streams at the FDA, and I want to show how relevant a lot of this work stream, not just to AI, but also to the pandemic that's ongoing right now. We have work streams on EHR and claims data, the utility of those to generate evidence. We have digital health tools work streams. We have decentralized clinical trials work streams, and then data standards. And we have multiple collaborations ongoing on AI to help the spectrum, the effects all the way to the actual technology. Can I get the next slide, please? I don't want to kind of get away without mentioning a little bit about the current pandemic. I think all of us are dealing with it on a daily basis, and the FDA is becoming, a very important aspect of everything we're doing in a daily basis. You hear quite a bit of reports right now around the potential utility of AI for COVID, but also I think I like the anecdotes that come up with the challenges, and just with the paper in the bottom on how the need for data was really a limiting factor when it comes to certain AI algorithms that could help potentially diagnose COVID-19 patients. So I think we should really balance the promise with the challenges, and all of us as a community, because I really don't think regulation alone or regulators alone, they're going to provide the ultimate solutions. I think this is a community have to come together, similar to what GAO here and the national academies are doing for us, bringing us together to start defining the important parameters. On the left, I put a new guidance that was published just in March and updated in April 16th on how the clinical trial conducted during the pandemic. And although it doesn't mention AI specifically, you will, if you read it, you will see the importance of digital technology. We're talking about remote assessment, remote monitoring of clinical trials, and multiple other aspects. I think we're going to take a lot of this learning and think how to apply it into the future. And it's a very important, I think, thing for us to think about. Can I get the next slide, please? So a couple of my last slide, I just want to mention, a general perspective on what is needed. I think we need to understand that AI is not necessarily the silver bullet for everything, and don't just follow the shining, a big thing that's happening, and start thinking what's feasible, what's really, what AI can help us now improve, and what could help us in 2 years or 3 years. What questions need to be answered before we get there? And then a shared understanding of the principles for designing AI system. I think this is important. For example, benchmarking frameworks, and I put frameworks because we might need different frameworks depending on the specific AI tool. And then what will transparency, audit trail, validation look like for AI? Frankly, we're still, the community at large, still thinking about transparency for observational data sets at this point. We have clinicaltrials.gov. We don't have something similar for observational studies. So we still have to work through those details as a community. We need to have a platform for early engagement with the regulatory agencies and across the board. One of the biggest take home for me at the GAO meeting that was conducted before the report was published in Boston is the divide and the divide of knowledge between the developers of AI and the regulators. And that was really striking for me because I'm used to talking to pharma and biotech, and they're very familiar with the regulatory frameworks we have. However, when you talk about AI developers, tech developers, I think there is a gap there that we have to bridge, and communication is going to be critical for that. And then convergence of multidisciplinary expertise is going to be really important, and you already mentioned educational and training programs connecting essential disciplines, and then modifying business processes and staff management. And I think this is a challenge to the agency and to other groups too, and how to think in teams rather than single expertise. Understanding ethical implication is essential, and then the needs for pilots, and start understanding the anecdotes of this technology. When you're dealing with a clinical trial, you're dealing with a discrete failure and success parameters. For AI, as mentioned before, failure is just part of the improvement. How to have our own staff understanding them and dealing with that in a comprehensive way. And transparency across the board, I really believe, is a cornerstone for all of this. Can you go to my last slide, please? So this is a paper from actually all the way from 2 Halloweens ago, which mentioned about the selection of Halloween costumes using AI. And I found it really fascinating, as simple as it is. It mentioned some anecdotes, and I highlighted some of them in the box. They gave an example of an AI algorithm that was tasked with sorting numbers while minimizing the errors. So the algorithm deleted the whole list because that's the best way to make sure there is no errors, right? There is no list anymore. And if you provide some really interesting anecdotes like that, and I think the take home is that prediction algorithm predicts the most likely outcomes and decision based on input data, not necessarily the most accurate answer for that setting. And AI may produce unpredictable, unconventional solutions, and the questions, are we ready to handle those? Can you move to the next slide, please? I think that's it for me. Thank you so much.
Thank you, Dr. El-Zerad. Appreciate your work on this and your leadership at FDA in helping evolve the regulatory framework around this. So very much appreciate it. And certainly last but not least, and we are leaving time at the end for Q&A, but let's hear from Dr. Danielle Friend, who's from the Biotechnology Innovation Organization, who also participated in the GAO study. So Danielle, over to you. Thank you.
Thank you so much. Can everyone hear me? Okay,
yes,
great.
You're coming in.
Well, perfect, thank you. First, again, I'd like to thank the Government Accountability Office as well as the National Academies of Medicine for your efforts on putting together this discussion, and certainly for inviting us to participate, and share our thinking. As mentioned, I'm Danielle Friend. I'm a Senior Director of Science and Regulatory Affairs at the Biotechnology Innovation Organization. Can I have the next slide, please? I thought, first of all, to kind of explain my perspective and the thinking that I bring to the table, I want to explain to you what BIO is for those of you who are not familiar with who BIO is. BIO is the world's largest trade association, and we represent biotechnology companies, academic institutions, state biotechnology centers, and other related organizations across the country. Our mission is really to advance biotechnology innovation by promoting sound public policy and fostering collaboration, both locally as well as globally. How do we do this? We pull together our members that work in the biotech space, identify challenges that are preventing innovation from being brought to patients, and we draw consensus and then work with federal agencies, Capitol Hill, and other stakeholders in order to promote and educate around those policies. Many of our member companies are using artificial intelligence and machine learning currently in their practices, and I think it has been very nicely highlighted by others during the discussion today, kind of some of the applications for both AI and machine learning in the context of drug development. I just wanted to briefly highlight, next slide, please. Oh, perfect. I just wanted to briefly highlight the utility of the GAO report that was put together along with the National Academies of Medicine. I think that these sorts of reports are very helpful in the work that BIO does by really outlining the landscape for a particular issue, highlighting the key challenges as well as some of the potential solutions that could be implemented in order to address those challenges. I won't step through the challenges in detail because I think they were highlighted very nicely by others in the discussion today. But one key element that I would like to maybe emphasize in particular is the topic of access to data in the context of using artificial intelligence for drug development. Again, I think it has been highlighted nicely in the discussion today, but one key element that I'd like to particularly emphasize is the need for timely access to data in the use of AI in drug development. I think on my next slide, I'll very nicely highlight how that has been very, it's been needed essentially in the context of the current pandemic. Next slide, please. So in the context of the current COVID pandemic, we kind of think of two particular challenges. One is the development of treatments and vaccines to treat COVID, but also we think about continuity of current trials that are underway for treatments that fall outside of the COVID space, so treatments for other diseases. In the context of COVID treatments and vaccines, as has been nicely highlighted throughout the discussion today, AI has been used to identify new targets. People are using it to identify new therapies that could be brought to treat those who are suffering from COVID and COVID-related symptoms. Additionally, AI and machine learning can be very helpful in identifying other key factors that can be used to assist with patient treatment, as well as identifying new ways to treat patients in the future. Just a couple of key factors here that I thought I would mention include factors that may predict worse outcomes in a particular patient population, identification of vulnerable populations, factors that might influence recovery duration or use of ventilators, as well as identification of patients for specific trials. I think that piece has been nicely highlighted during our discussions today as well, as identifying kind of the right patients that should be included in specific trials. As I mentioned, outside of the space of development of treatments for COVID, in the context of other clinical trials that are currently underway, there is currently a need for continuing trials and really making sure that those trials can continue despite the disruptions that COVID is presenting. In particular, BIO did a survey in the middle of March to really survey our members around ways in which they are attempting to continue their clinical trials in the context of COVID. And overwhelmingly, what we've seen is that sponsors are doing their best to implement digital technology approaches, allowing them to collect data from patients while patients are potentially in their homes, as well as implementing AI approaches to help mine that data, to help monitor the data from patients as that data is coming in. So just emphasizing that in the current context of the COVID pandemic, there are multiple uses for AI. And again, I want to emphasize from my previous slide, the need for data kind of in real time to inform decisions around COVID treatments, as well as the most appropriate patients to include in those clinical trials is of utmost importance. Next slide. For my last slide here, I just wanted to kind of emphasize a few key next steps, again, kind of pointing to some of the pieces emphasized in the report regarding policy and next steps. I know Rebecca touched on some recommendations as far as policy that could be carried out in order to better implement AI and machine learning throughout drug development. And she did, allude to the fact that we could follow the status quo and kind of let things unroll as they will. I think from the bio perspective and certainly from the industry perspective, companies are currently implementing machine learning and AI to quite a large degree. We see the need for regulatory clarity in being able to use AI and machine learning in the context of drug development, but also review. And we really see the FDA as being a partner in this activity and making sure that there's regulatory clarity. I think CARE emphasized several activities that the FDA has implemented as of recently, and we're very appreciative of those efforts. And we'd like to emphasize the continued need for activities such as this webinar today for stakeholders to come together, share and discuss use cases, benefits, and challenges of AI approaches, and also to some of the points that were made earlier in the discussion today, share concerns, especially from the public, so we can make sure to come together as stakeholders and carry out and push AI forward in a way that all stakeholders are comfortable with. Certainly after public forum and public discussion, it would be helpful for industry sponsors to have guidance from federal agencies regarding how AI and machine learning will be reviewed and what regulatory requirements will need to be met in order to incorporate AI and machine learning in their drug development practices. I'd also like to emphasize that there's certainly also an opportunity for AI and machine learning in the context of review of therapies, and I think certainly further discussions on the benefits and challenges of those approaches would be appreciated as well. I think my next 2 points, really emphasizing the need to ensure that drug developers, regulators, and other key stakeholders, keep pace with the full potential that AI could bring to bear. I think this does touch on, again, the need for the expertise, both within companies and the federal agencies, to bring that forward, but I think also touches on the fact that, again, part of this, the issue with the use of AI and machine learning is really the data access piece and the timing of being able to gather that data, use that data, and mine the data. So really needing to keep pace with the potential advantages that this technology brings. And then lastly, I think another point that several folks on the discussion today have already emphasized is just the need to ensure that AI addresses inefficiencies, in drug development, in addition to making sure that it still aids in safe and effective development of medicines. We want to make sure we can evaluate the use of AI and ensure that it is in fact bringing efficiencies to the drug development process to really make sure that therapies that are safe and effective can be delivered to patients as quickly as possible. And I think that is the end. So I think we will move to a question and answer session.
Yeah, thanks very much, Danielle. So we're a little bit behind in terms of our timing, so we're going to try and go over a little bit for those who are willing to stay. Some of our experts, thanks to all of you speakers and our panelists here, maybe it'll stay a little bit longer, but I think we'll triage the questions and do some questions for those experts that can't stay beyond 4 o'clock, so meaning Eastern time. So I think I'm turning it over to Mike, and he's going to ask the initial round of questions. Is that right, Mike?
Yes, thank you very much, Tim, and thanks again to all the panelists for the superb presentations. Actually, just a couple of housekeeping items before we move, and that is, first of all, that the slides and a recording of the webinar will be posted on the NAM website after the session. And thank you to Noor for reminding us that. And if you have questions on that count, Noor Ahmed can field them. Secondly, we do have extra time, or we're going to carve out some extra time. And in order to ensure that those who have to leave at 4 have a chance to answer questions, I'd like to turn first to a question that's directed to Marlies, who does have to leave shortly, and it's what's the role of AI in low resource settings, that is development countries?
Thank you very much. So I think the role of AI in low resource settings is potentially even more leapfrogging than what it is in developed countries. I think that the challenge is that we have to simultaneously work on how and where do we, in a smart way, embed AI, whilst we also have to work on we still have to work on digitizing data and digitizing the healthcare workflow itself, because it's not an integrated digital system at the moment. But the opportunities are the same. We think about the diagnosis of diabetic retinopathy in India, for example, which is a use case that's already being used. The application of radiology for first-line diagnosis, or at least screening out definite negative cases, which is another application. Micro-targeting and predictive analytics for thinking about which people do we need to, in a proactive way through community health services and frontline healthcare services, do we need to go and target for additional or differential care? These challenges and issues are no, and the opportunities are no different. It's just we have to work on some digital building blocks that are more fundamental, that have already been done in developed settings.
Thank you very much, Marlies. The next question is for Michael Matheny, and it's related to the issue of the use of AI in performance measures and quality data, and it essentially is what can AI be used, how can AI be used to improve the quality and reliability of health data? And a related question is, are there ways in which we might envision AI accelerating the capacity to measure the performance of systems without having, and potentially reducing the individual clinician-patient interaction reporting burden?
Oh, those are both good questions. So I think there actually is a lot of opportunity for basically surveillance and augmentation of data quality. So there's a literature around detecting gaps in administrative coding, detecting even gaps in documentation of data as a patient is seen, and if there's sort of a discrepancies in how the text of the clinical encounter is presented versus how the structured representation of the patient encounter is done. So I think there's a lot of opportunity for AI to learn and to help sort of improve documentation. But I like the second question even better, which is how do we let AI help the healthcare system itself reduce the burden of documentation? And I think there are in this area also, there's literature around trying to detect as providers are typing, automatically detect encodings of what they're typing, so that you can recommend orders and recommend structured data encoding behind that in real time as it's happening. And there's a lot of things ongoing that could potentially help reduce the overall documentation burden as well. So excellent questions.
Thank you, Michael. A question now for Jack Resnick, and it relates to the fundamental working elements of artificial intelligence, and that's the data that are included into the analytic framework and drive the algorithms. And it is focused on how we can improve the access to data. What's the most practical approach to permissioning if we have the twin goals of, one, emphasizing patient agency and control over their own data, and on the other hand, of maximizing sharing and use of data for continuous learning and application in AI activities?
It's a great question. I think, patients are going to vary tremendously on how comfortable they are with us using their data for a variety of purposes. So I think, which is why I think we need to have an open open and honest conversation. I think a lot of them are actually going to be quite comfortable when we tell them some of the exciting things that AI can do with their data, but they're going to be less excited if they don't feel like we've been honest with them up front about how we're going to use it. Somebody in one of the Q&A chat boxes asked also sort of about how HIPAA plays in with this. And I think, HIPAA really doesn't regulate de-identified data that doesn't have any of the 18 identifiers. So in a way, it's not that useful for some of the challenges that we're facing. But we do know that the big data aggregators can take a big data warehouse of de-identified medical data from a medical institution and re-identify all those patients. So I think that's why we really think a model of meaningful consent. And some patients may say, when you ask them, do whatever you want with my data on an ongoing basis, you don't have to ask me repetitively. And some may say, I don't ever want my data used. And there may be a lot in the middle who actually want to get a message when a med center wants to share that person's data with a large company in Palo Alto or somewhere. So that's what I think we'll need to do, is to actually have systems in place where patients can interact with that system. And a simple sort of click through that says, I approve, that's the only choice, as we see with a lot of apps right now, I think is not going to satisfy people.
Thank you, Jack. Before I turn it back over to Tim for the next 3 questions or so, let me ask if there are other panelists who want to comment on any of the questions that have just been raised.
Can I jump in on that one?
Yes, please.
So I tend to agree with my learned colleague about the disutility of these click boxes, but I have to say, if you really take informed consent here very seriously and ask yourself, what would meaningful informed consent look like for future data use? It's quite difficult to imagine. If you ask me as a patient, a very informed patient, it would be very hard for me to know ahead of time all the risks and all the benefits. And so I think that we may want to think more beyond the individualized consent model to other kinds of forms of group representation, whether that is governance structures among patient groups or within a hospital or the like, rather than putting the burden on individual people to make decisions.
There are opportunities there, but I think it does fundamentally require those conversations happening with communities. To the extent that a large academic medical center is going to think about sharing records, I would recommend that they go to their local newspaper and have a public discussion with their community before they do that, rather than getting caught later.
Thank you. Anyone else want to chime in on that? Okay, let's move it over to Tim.
Great, thanks, Mike. So yes, thanks very much. I'm going to start off with Dr. El-Zarad. So this is just a question about the framework for drug development pathways. So the key thing here is how FDA is planning to innovate the regulation of these new technologies that include AI, but don't exactly fit into the existing framework, so they're not neatly fitting in. So can you please speak to that? Thank you.
Yeah, and again, I'm going to approach this from a policy perspective. I think there are multiple ways we're approaching this. As Glenn mentioned before, we have our own regulatory frameworks that we have to kind of utilize. However, we're trying to give you one example. We're trying to build bridges between the Center for Devices and Center for Drugs, because the realization is that a lot of those devices, a lot of the AI tools are going to make that bridge for us anyway. They're going to come in a form of apps, for example, that support the therapeutic experience for a drug. So having both insights from the devices and the drug side, I think we're increasingly essential, and we're trying to make sure that's happened. We have a lot of collaborations that's happening right now around the use of advanced analytics, around the use of AI, and around standardizations for data streams in general, that I think is all going to feed into this. The real-world evidence is an example of this. We have 7 different active work streams within the real-world evidence platform that we have, including decentralized clinical trials, digital health tools, and beyond. And I think all of that's going to feed into the way we're going to develop our approach to AI. And when we say AI, and we're using it as an umbrella term here, of course, I think it's really multiple challenges across the board, and it's going to depend on the context. So right now, the case-by-case approach, I think, is the way to go in a lot of the scenarios, to understand the context and the risks involved in each one of those. However, we do have to start thinking about platforms, about kind of full frameworks to approach this. Our collaborations, actually, we have certain collaborations right now with our stakeholders, including with the International Telecommunication Union, for example, on like the understanding the technology itself and the regulatory considerations around it. So I think it's multiple steps, and it's going to take us it's going to have make us have to do a lot, really, not just one approach or not just one initiative to address this question. I hope this is a little bit helpful.
Yeah, no, that's very helpful. Actually, what I'm going to do is just pivot to Ken and just see if he, just on that particular question, based on what he sees in his Center for the Study of Drug Development. Ken, if you would care to opine on that question and Dr. El-Zarad's perspective as well, please.
If you're talking about real world evidence in particular, that obviously is an area where we see the industry moving aggressively to develop capabilities. Just to sort of build on what was said, we know, for example, that of the top 50 largest pharmaceutical companies, over 75% of them now have a central function with a large staff, and they're looking at real world data and evidence not only to for the purposes of label extension, but to augment clinical trial activity and ultimately even to replace the need for conducting clinical trials. And as was suggested, the current response to the pandemic has even raised greater interest in relying on real world evidence to complement evidence gathered through our traditional or randomized controlled clinical trial model as a way of even accelerating drug development activity. So it's a very, very important area, and one where the electronic health and medical record, as well as aggregated observational data, is expected to become far more valuable and important over time.
Okay. Thank you. Let me then just pivot. Danielle, there's a question just about examples of just machine learning models that have actually been used. Sometimes AI is so high level and conceptual, it just needs to have those stories, like where has this actually shown out and things. So from your perspective at Bio, and what are some sort of problems that you all have seen in terms of solutions in healthcare at this point? You're on mute, Danielle. I just want to make sure you unmute. Go ahead.
There we go.
Great, thank you. Yeah.
So, sure. A lot of the conversations that we've been having with drug developers have been focused a little bit more on the front end of the piece of drug development. So really looking at AI to identify new targets that they could target in their particular disease state. Taking a look at existing therapies and what those therapies could be applied to, other disease areas. So much of that is on the front end, and there's a lot of that work that's currently ongoing, but I think we haven't seen a lot of that necessarily come to fruition quite yet. So again, a lot of the focus is kind of on the front end, the discovery piece. I will also say the other pieces that we're starting to hear a lot about, but I think there's still some time for it to come to fruition, is really getting to the piece on identifying the correct patient populations for your particular trial. So are there patient populations that would respond really well to your particular therapy? And can you then run a clinical trial with those specific patients in your patient population? So I think there's a lot that's still evolving. Companies are still learning at the moment, and there will be a lot for us to see in the near future.
Okay. One of the big things, I'll just ask the panelists in general, open this question, have a short response, and then I'll turn it back to Mike for another round of questions. But this just goes down to a typical concern about AI is essentially the weaponization of this. It goes down to the security of the data. In this case, the weaponization context may be, the loss of privacy, any sort of exploitation, unintended or otherwise, or directly intended. So can anyone speak to that particular concern in terms of mitigating the risks of those things? Thank you. So Dr. El-Zarad, do you all have a concern about that kind of hacking and security of systems and so on? And if so, how do you deal with that?
Yes, I think that's a constant concern across the board for digital health tools in general that rely on signal and connection, for example, and even like processing. We've seen that, for example, in the artificial pancreas models. So that's a constant concern, and this is a big part of the review that the Center for Devices do for those devices. Now, I think when it comes to AI, it's going to take us a little bit at a higher level of that challenge, and I think somebody commented already on adversarial kind of approach to testing AI, and I think that might be a mechanism we need to look into. Context, I think, is going to be also important across the board for this. You guys are all aware with the issues with Zoom, for example, which is, just before COVID, Zoom was the standard for telecommunication. We've heard about all the hacking issues with it, and I think we do not. I don't know how much we can do to prepare for what's coming, and I think we're gonna have to have a little bit more of an active mechanism to monitor potential failouts and potential issues moving forward, especially for high-risk AI algorithms.
Okay.
So Sonu, what I'd like to add is that when you deal with situations like data compromisation and hacking, those of us with privilege can understand what that means and can navigate the chaos that will end up in one's life if your healthcare data is used elsewhere. But people without privilege, might not have the opportunity to truly understand what's going on, and then might not have the resources to navigate the chaos either.
Great. Thank you. Let me just turn it back over to Mike for another round then.
Thank you, Tim. And Sonu, may we just keep you on the floor here, so to speak, and ask you to elaborate a little bit. Several people have referenced the issue of health equity. Health equity, of course, is the major, most glaring deficiency in our society in many ways. And AI has been identified as a potential problem and as a potential solution. If you're laying out the agenda to ensure that AI is used to the greatest benefit in reducing health inequities in the nation, what would your 3 or 4 top items be?
I think starting with making sure that there is guidance and governance as we collect data and use it appropriately would be up there, followed by ensuring that as the tools are developed, the end users in all their diversity are engaged to better understand. We have seen, for instance, the reality of shelter in place, meaning starvation in place for some people. We cannot have things like that happen, exacerbated with the kind of power AI has. And then beyond that, I would actually say that the biggest challenges and opportunities in healthcare that AI could and should be used for, in my opinion, are public health and issues around social determinants of health. Today, clinicians at the front line, might have amazing ways of doing a diagnosis and offering a treatment, but to actually have it executed equitably, what comes into play are things like social determinants of health. So to be able to use AI to better understand what that means for each patient, who is that person, and what are the pieces that they navigate, and as the diagnosis and treatment is customized and personalized for them, what does it mean to put in the resources at a communal public level to address and solve the problems at hand?
Thank you, Sonu. A question for Gil, and then we'll turn it back over to Tim. Gil, can you give examples? Do you have some favorite examples of how machine learning models have been used to solve some problems in healthcare? Did I miss Gil?
Looks like Gil's on mute.
Oh, okay. Gil, are you on mute? Well, does anyone else want to chime in on that while he's finding the unmute button? Some of your favorite examples. Michael, I bet you have some.
Sure. So I think some of the most mature examples are some of the tools in the imaging interpretation space. So those that sort of deal with, interpretation of, as Jack mentioned in the chat, diabetic retinopathy, abnormal imaging interpretation on radiology, chest X-ray and CT, skin cancer lesions. And so those, I think, right now are probably the ones that are the farthest along towards clinical impact.
Mm-hmm. Thank you, Michael. Tim, over to you.
Thanks, Mike. So let me just ask our panelists. This is one of the things, I'm deeply involved in terms of the policy making in DC and things. And one of the challenges oftentimes is policies that are easy to say but very hard to implement in principle. So this one is a challenging thing. We all know that we need to overcome, data silos across different entities. We need to have better access and data sharing. How might we accomplish that, right? We have the risk that was spoken to earlier, which is too much aggregation, too much power in one place could be a bad thing, but we still need to have some kind of sense of sharing and building up one another because, as you all know, in the data analytics and the machine learning stories that build out of that, we need to have that sort of sharing paradigm to do that in an era, or especially in healthcare, in the context of HIPAA or other concerns. So what are some things that we can think about or speak to our policymakers in terms of that data access and sharing piece? So let me just open it up to our experts to speak to that. Thank you.
One quick example that I loved watching, actually. Again, I'm bringing back the real world evidence program that we have. And typically when a sponsor interacts with the FDA, they interact with the FDA with a specific context of specialized meetings, certain types of meetings. World evidence, we realize we need to engage with our stakeholders at a very early stage when things are still like in the very early development, to have that exchange of thoughts between our experts and the developers' experts, the experts from the developer side. And we start having a subcommittee meetings where a developer or a sponsor can come in and suggest ideas, and it's usually more comprehensive idea. And we have this open dialogue, and that's the reviews of that actually communication is very positive. And I kind of felt like we really need to have more of that kind of an approach where we can sit side by side and have that dialogue, a regulatory perspective and a developing perspective, and engage at that level. What are the caveats? What are the issues that need to be addressed? And this is not a regulatory meeting, so there is no regulatory decision. It's just an exchange of thoughts between the two sides. And I think we need to do more of that, bringing everybody together. And I just want to mention that as a great model that I thought working really well.
Great, thank
Maybe
you.
to add to that, I'll emphasize the need for pre-competitive collaboration among industry and other stakeholders. I think can certainly support that as well. I think another important piece about sharing and access to data is making sure that even if data are in different silos, that they are interoperable, or that they have similar common data elements, so that at some point they can be potentially combined or put together in some way to add to the data set.
Great, thank you. Anyone else want to opine?
Let me add one question to the mix, and that is, as we go to the last minute or so here, if you had the capacities of the National Academy of Medicine and the GAO in mind, what would you most like to see either organization, you don't have to name which one, most do to try to advance the potential that we all see here, but to also safeguard against the harm that we fear? What is your favorite candidate for the most important issues to engage? Anybody?
I'd love to see a collaboration between those two organizations and others to actually create some kind of vetting process, say measured by the quintuple aim, and giving ratings to products and services that are put out in the world of AI in healthcare to better understand, so that as a consumer or as a hospital organization or a clinic or as an administrator, you have some neutral vetting of what's going on versus having to go through every minutia in order to truly understand what was done, or relying on marketing, because those are the two options we seem to have today.
Thank you, Sunan. Others?
I think one major challenge, and it was mentioned today, is the informed consent, and how, you know, I think it's the issue there is that multiple organizations would want to have a say here, including OHRB, of course, in the States, and NIH and FDA, I imagine, and multiple other non-governmental agencies as well. And I think coming to an understanding of how can we really have a meaningful informed consent while utilizing AI, for example, especially that we, as mentioned again before, we do not know necessarily the exact outcome of a lot of those tools and the actual impacts of them. Actually, OHRB had a workshop, I think 6 months ago or so, and it's available publicly on data privacy, and it was case after case of scenarios, how like really unpredictable a lot of this utilization of this large data set. And I think coming to an understanding how collectively we can do justice in an informed consent pattern, and then having the understanding of all the small particulars that we have to think about will be really helpful. Again, I'm not suggesting that for GAO or national academies alone. I think as a community, how can we get there? I think that's a challenge.
Thank you very much. Well, we're out of time. I want to turn it over to Tim for any closing comments he might have. But I will underscore that the record is open. So any one of you who has other thoughts in mind on that count, both on the panel or in the audience, please feel free to send them our way. Tim?
Yeah, thanks, Mike. And I'll just quickly say thanks to everyone again. It's been a phenomenal discussion, as our participants and our audience probably can feel the weight of the issues in terms of this conversation demands, you know, cross-sectoral collaboration, interdisciplinarity, you know, holistic look at it, not just the tech for tech's sake, but the idea of the ethical, legal, social, economic issues that wrap around that. So I very much appreciate the rich discussion today, and appreciate and take to heart, Mike, it was a great question about what can the academies and GAO consider on this moving forward, be it data sharing standards, informed consent, etc. There's so much to do, but we look forward to staying in touch and working with this overall community to try and move this forward. So thank you again, and back to you, Mike.
Well, underscore the thanks to all the panelists, the audience who has tuned in, and to our partners in this GAO, and especially to the staff who have done a marvelous job, not only around the webinar, but in all the work that has led up to the two products that we focused on and will be focusing on into the future. So again, great appreciation to all. Stay tuned for the next activities and stay safe.
Very well. Thank you all.
Bye now.
Thank you.